Um, We have a quorum walking in the door. So, Senator Eccles, do you mind leading us in prayer, open us up in prayer? You're number 10.
Let us pray. Dear Heavenly Father, thank you for allowing us all to be here today. God, I pray that you give us clear minds so that we can think through and make the best decisions for the people of Georgia. In your name I pray, amen.
Thank you. We have two bills today, House Bill 1078, Chairman Petrie is here, and House Bill 1083, Leader Bruce Williamson is not here, and I'm going to be doing that one, so I'm going to give you a little heads up. I've given you no heads up until just now, so I apologize about that, but I'm sure you can handle it. So, Representative Petrie, you can be here or there. You want to sit down. That's great. Witness number 2.
Witness number 2.
We do have, on 1078, we got 1, 2, 3 people that have signed up. Tell us a little bit about your bill, and the floor is yours.
Thank you, Chairman. And my understanding is my senator is going to be carrying this bill. So I think you got this one also.
Happy to do it.
All right. So, Mr. Chairman, House Bill 1078, this is a Department of Community Health bill. As I think most of you may be aware, last year the department began studying the idea of doing a PACE program in Georgia. And what this bill is the enabling legislation for the Department of Community Health to develop and implement a PACE program. PACE is an acronym which is Program of All-Inclusive Care for the Elderly. And Mr. Chairman, you and I have had some experience with the SOURCE program in our careers at home, a waivered service that long ago was really almost patterned after PACE, although it was a waiver and it was not a capitated program like PACE. This is a true PACE program. The goal, give people opportunity to stay out of institutions, keep them in the community longer. When we do that, we save money for taxpayers by keeping people in a less institutional setting, and we give people a better quality of life. So what this program does is basically the provider would provide all of the kind of all-inclusive care for these individuals that are going to be age blind and disabled, dually eligible, Medicaid and Medicare. And so they're providing the preventative care, the primary care, the acute care, and the long-term care. All of that is provided by these individuals. It's a voluntary program. They choose this as an alternative institutional placement. And I said earlier, it's a capitated program. That's what makes it different from our waivers that serve this population today. It's currently in 32 states. I do want to emphasize that initially there'll be 3 sites. Fulton County, and these were sites that were studied by the department, had the population that could benefit from the services: Fulton County, Bibb County, and Chatham County. I think that's pretty much explains it, Mr. Chairman. Glad to answer any questions.
We have any questions from the committee? If not, we have 3 people that wanted to testify. All right. There you go.
Hey, Ed.
To my friend from Chatham, great to have you here. So to understand, and again, I'm not by any means an expert at this, and I just appreciate your expertise. So if somebody's goes into an institutional setting now, obviously the institution that takes them in has full responsibility for their well-being. If they're at a home setting, they get services, but there's no strict duty to provide those services. That if someone doesn't show up, it's kind of I've had constituents that have called me that they're getting home care, and if the person doesn't show up to change their diaper and bring food to them, it's like, oh, sorry, we missed it today, we'll come back tomorrow maybe, and it's just, there's not this duty. Does this create the same duty that you have if you're in an institutional setting, that you provide care?
Yeah, so let me first of all say, so we don't know where there's, in that analogy you just used, is that private sector services? Is it services through a Medicaid waiver? It could be is it home health through Medicare? So it could be from a multitude of angles. But to answer your question you're looking for, is somebody going to oversight all of this to see that those services are provided? Yes, and that would be the PACE provider. And so yes, it will better ensure that those kind of gaps don't happen. That's correct.
And I know we don't like to talk about lawsuits and stuff. I'm just talking about real legal duties, and they have a legal duty to provide the care. It's not a sort of a secondary service then. It's that, okay.
It's an all-inclusive, they accept, so the provider that chooses to be a PACE provider, and there are 3 now that are interested and we're working with the department, they're taking on that burden to provide all of the care needed for that individual.
So if a family member of the person getting care saw that they were missed, 2 or 3 days in a row, and weren't getting critical things, you'd have the basis of a suit. You can actually force them to do that. You have because today you don't have an action to do that.
Well, I think what would happen, so in the world we live in today, I want to make sure I'm speaking clearly to this, so we can't ensure that always an employee is going to show up on time or something of that nature. What I'm saying is that provider, their duty is to make sure that if somebody's not there, they get somebody else there, which, by the way, is already the duty of home care under licensure. So, but I can't tell you that there's not failures, because there are failures, as we all know, in hospitals every day, in skilled nursing facilities every day, and yes, in community-based services every day. But the folks whose duty it is to see that that individual is being served and served well, it will be the provider, the PACE provider of these individuals that voluntarily choose this service as an alternative to skilled nursing home placement.
I love this bill, Mr. Chairman. I just had to ask that question. I
No,
appreciate
thank
the author.
you.
I
Good
just,
question.
I won't belabor the point. I had a constituent who is wheelchair bound, can't get out of their wheelchair and bathe themselves, would have sat in his own business for 60 straight days. No one came and checked on him for 60 days. Only friends did that for him. Because when you get home care now as a disabled person, it's not I don't know the right term. It is not there's not the obligation that you have when you're in an institutional setting. And if this closes that gap, that would be a huge.
So was this in a skilled nursing facility, or this was at home?
No, they were at home,
They're at home, I got you.
and they choose to be. They could have been in a skilled nursing facility.
But part of the qualification, just for education for the committee and folks listening, is that they had to be eligible for a skilled nursing facility, i.e. nursing home.
They're going to meet a level of care
to
for skilled
be eligible for this program.
Yes, sir.
And that's,
And he opted to be home. And
Sounded like it,
But when he
yeah.
opted to be home, that was the fatal mix.
Yeah,
Once he opted to be
that's
home,
tough.
he didn't have the guarantee.
right.
So I'll say one last thing, Mr. Chairman, if I may, to the very good question. Senator Sessler, so here's where I think this would be advantageous. Unlike some of the other programs, like through Medicaid waivers maybe, and where you might have limited choices. So here's what will happen with a program like this. The provider, if they discover that the individual being served says, I don't like ABC, I don't like this agency, they can replace them and put somebody else in there. And they have free reign to do that. And so I think that, again, as you get feedback from the individual served, your goal is make sure they get served and also make sure they're satisfied. Because, again, they're choosing this service as an alternative to skilled. Remember, so just to be clear, everybody is entitled to skilled nursing home placement. It is an entitlement. Home and community-based services are not entitlements. And so people choose this, and yes, somebody's failing, replace them. And I think this makes it easier for a program, the PACE provider, to say, you're failing us, you're out, we're putting somebody new in. So I think it helps resolve that problem.
Appreciate it. We have Deborah Stokes, and then Tom Bauer, and then Kathleen Benton will be last. Whichever one you want to do. Now's good. All right. I'm sorry. I skipped my vice chair
Yeah,
there.
I really like this idea, Mr. Chair, but I had 2 questions for you. One is, can someone go from a SNF to PACE? In other words, once they're in a skilled nursing, if it seems appropriate that they could be provided service at home, can it go that direction?
Unless someone here with the department tells me otherwise, my answer is absolutely.
Okay.
Yes.
And then the second thing is, you said several times it's voluntary. What's the outreach going to look like? How are people going to know that they have this option?
That might be better coming from the department, but that's a great question, Senator, and I think the department might better answer that.
And let's do 3 people to testify, and then we'll circle back with questions and go from there. Ms. Stokes?
Thank you, Mr. Chairman and committee. My name is Deborah Stokes. I'm Executive Director of the Georgia Council on Aging and its Coalition of Advocates for Georgia's Elderly. We are very much in favor of this legislation, as it will help the growing aging population be able to stay home longer. And we know that that is the goal. That is the best place for our seniors to be, is at home with all of the services that they need. So we are very much in favor of this bill.
Thank you.
Thank you.
Tom Bauer.
Thank you, Mr. Chairman, members of the committee. I'm Tom Bauer with Leading Age Georgia. We serve at least 125,000 seniors in our various facilities and adult day centers. We cover the gamut from upscale retirement to subsidized housing. Ms. Stokes was very eloquent exactly on why we're supporting this bill. We would like to see as many options as possible for seniors to get the services they need, access the services without being in skilled nursing. In particular, we have many subsidized homes and HUD facilities and things like that, and these are folks who are living independently, and they're going to get to a point where they can't live alone, and this would be another tool in the toolbox, to use the phrase that everybody uses around here. So we very much support the bill. Thank you.
Thank you, Mr. Bauer. And Kathleen Benton. Ms. Benton, if you just identify yourself, that'd be much appreciated.
I'm Kathleen Benton, and I'm the CEO of Hospice Savannah, and we're out of Chatham County. I'm an interested provider in PACE, and I've actually been studying PACE across the country for the last 2 years to see the benefits it could have in our own state. And all of our neighboring states actually have PACE as well, and it's actually very instrumental. We serve about 4,000 patients and caregivers, so we've seen the deficits, just as you've talked about, in what we can't do in health care, and PACE is an excellent disruptor to all of that. Very briefly, I felt that it's helpful for you to meet a fictional patient named Mary. Mary is a patient that we see every day, an 85-year-old with congestive heart failure, Alzheimer's that is advancing, and pulmonary disease. Her son and daughter work every single day to get her to the neurologist, the cardiologist, the primary care. She's dealing with what you talk about as far as home caregivers who don't show up. The family is exhausting themselves supplementing these home caregivers. And Mary doesn't want to go to the nursing home, though she is eligible. The family is exhausting themselves. Healthcare resources are being exhausted. Mary's gone in the hospital 7 times in a year. She's gone to the emergency room with falls 3 times in the last year. So how could the trajectory be different for Mary's family with PACE? Enter PACE and you have immediate transportation. So the first step is to take this off the family. The home caregivers go into the home and get Mary ready every day. In answer to your question, if they don't show up, the entire team knows about it, because you also have interdisciplinary review of the providers, and you have the transportation group that will be out there to pick up Mary for one of her appointments that are scheduled to see neurology or cardiology. Then Mary will be taken to the PACE clinic. PACE is a structured building that is built around the needs of patients. If Mary needs fluids that day to make sure that she's not left dehydrated, if Mary needs physical therapy to make sure that she doesn't fall when she gets home, all of that occurs during the day. So Mary is well taken care of and reviewed by this PACE program. And at night, Mary goes home. Sometimes the family helps to get her to bed if they're not there because they're out of town or because they just can't do it with all they're doing working themselves. Then the PACE will also show up to the home and make sure that Mary gets a nice meal and goes to bed. If Mary needs her hair fixed the next day or needs the dentist, the PACE covers that. If Mary has a fall in the home in the middle of the night and needs to call 911, the PACE meets her at the emergency room, makes sure she doesn't stay at the hospital too long, that a subsequent surgery goes well, and even rehabilitation in the nursing home is followed. You utilize all of the services that are in healthcare, but you bind them all together with the PACE. And that's really the benefit of having this program in our state. I'm also open to take any questions, but I'll say I am so grateful to Senator Watson. I'm so grateful to Representative Petrie and to the Department of Community Health for supporting this innovative program. Put simply, it will help keep people in their homes with round-the-clock care and really help families do this.
Any questions? Senator Sessler? Hold on, let me get your mic. Okay.
Just very simply, again, I'm excited, appreciate your being in this, and I appreciate your very clear presentation. That's what I was looking for. So to be clear, the PACE provider is fully accountable for their outcome.
Fully accountable and fully accountable to the bottom line. If they don't do a good job, they're going to pay more because Mary or any other patient is not going to do as well in the health care continuum.
Thank you.
No, I got you. I see. Everybody see that particular point she made? 8. Senator Hodges.
I would imagine there's a substantial difference in cost. Can you speak to that a little bit?
Absolutely. In compared to nursing home patients, it's about a 12% cost reduction with PACE. And most of that is because the care is no longer disjointed and the capitated network is motivated to make sure that there's no redundancies. So for example, if the patient's going to a neurologist and a nephrologist, all of that is married together in the interdisciplinary team. Medication management is very thorough, and there's less hospitalizations and less number of days in the hospital during the hospitalizations, which allows the resource reduction.
In other words, it is Senator Sessler said, if someone doesn't show up and they get a bed sore, it's going to cost them a lot more money, and their capitated fee will certainly not cover their cost by any means. So they're motivated on multiple different levels.
Exactly.
So, and it's generally cheaper to provide care in someone's home than it is in a skilled nursing facility.
That's exactly
Any
right.
other questions, Ms. Benton? We sure appreciate you coming. That was very insightful. Appreciate your example there. Thank you.
Thank you.
I apologize.
For the department.
Okay, all right. You're on number 10?
Yeah.
No, 11.
Oh,
Okay.
11, yeah, 11.
By the way, just the internet apparently is down.
Yeah.
And but we're being taped, and it will be available later if anybody is dying to listen to us again. Right, Mr. Hood for the Department of Community Health.
Yes.
Thank you. Senator Chairman Huffstetler has a question. I
So
think.
we had looked at a model a year or so ago where on our subsidized housing, we had people that we were trying to mingle on the same floor, and the rules wouldn't let us do it. I don't know if you're familiar with that or not. We're trying to get a pilot done on it.
Yes, sir. I think I'm familiar with what you're referencing.
So, and we never really got to where we wanted. My question is, does this help in that?
I think it does, because those individual members, as was referenced earlier in subsidized housing, they would be individually, if they meet the SNF level of care, they would be able to enroll and still stay in that subsidized housing, and then they would have all the benefits that PACE would offer, and it doesn't have the restrictions that of a licensure that you're referencing.
So they're not mutually exclusive.
Right.
Okay.
Okay. Senator Chairman Huffstetler, number 5 still. I should have had that memorized, shouldn't I? There we go.
I'll make it quick. The geography, we talked about Fulton, Bibb, Chatham. What's the prospects of this being a statewide thing, and what's going to be required to do that?
Yes, sir. So what we've done is last year the legislature directed us to do an assessment. We reached out to the National PACE organization, and they have a formula which goes through an algorithm and demonstrates where PACE would be most successful and where there's sufficient numbers of eligible members to make it successful from an investment standpoint and operational standpoint. And in doing so, we asked for those specific locations because we had interested parties that already had facilities there that would go to a PACE organization. You basically have to have a 10,000 square foot building that would meet the services that were referenced earlier in testimony, and then you can serve a population of zip codes that surround that within a certain mile radius. With their algorithm, they demonstrated that those 3 had that. largely, we think that other population centers are going to be eligible. We didn't specifically look at those because we didn't have the same interest that had been demonstrated, but certainly Fulton and DeKalb showed the greatest number of population as you might expect, but I also expect Cobb, Gwinnett, Columbus, Augusta, so forth, that, would qualify.
But if we act on this and the CEO who spoke to us, who's doing this in Chatham, decides, you know what, I'm going to open up a Cracker Jack facility in Gwinnett County, they can start providing the service as long as the capabilities there, or do we need to appropriate dollars? Do we need to act again legislatively, or where does that stand?
Sure. Let me explain it a little bit further. So what has to happen, what this is authorizing the department to do, is to go to CMS and submit a SPA to add this to our state plan to authorize PACE services as a Medicaid-covered service. PACE is a Medicare program. It's in a number of states, but it's set, all the rules and regulations are set by Medicare, which is why this legislation is really so small, because we're going to rely upon everything that Medicare has as an implementing entity. And just to add to that, they're also a subsidy to this program. They pay a substantial amount for those who are dual eligible, and this is largely focused at a Medicare population. If we did not have PACE, which we don't have today, all the other things that we offer that are on Medicaid are 100% state match. So this has this subsidy from Medicare as well. So with that, that's how we will implement. But in doing so, and to identify locations, what we have to do is to make sure that there's a readiness component of that. The way that we initially intend to do that is to hire a contractor to go out and do what is known as a request for qualified vendors. They'll set out all the things that would be necessary, largely that building and staffing and all the things to demonstrate that a facility is going to be ready within a certain time frame. And that's really why we focused on these three, because we knew we had identified providers who likely would be able to meet that. If we see additional interest, we would come back the next year and then we would do that again and allow for those additional providers, which is what we expect to do. I will say...
But it would not require legislative action?
No, sir.
Yourself. Okay.
No, sir. I do expect that it might acquire additional appropriations. We've only got a small number this year. If we have to do additional administrative tasks and actuarial services and all that at a larger scale, we do anticipate that we would bring that forward as needed.
Thank you, Ms. Hood. Chairman Walker.
I'm going to borrow Mike 12, even
Gotcha.
though I'm not even on the internet, but like the concept, certainly. I wondered if meals are part of it. And my other question is, well, I have two questions, if you don't mind, Mr.
Sure.
Chairman.
So I believe that it's contemplated any service component that they would need that they would have met. I mean, it's a total managed care model. So if there's that need, then I suspect that they will find a means to do that, whether through its other service programs to provide meals or Meals on Wheels or whatever the case may be. It's going to vary probably depending upon that person's circumstance. Certainly I expect the facility, which really acts in addition to the healthcare component, really as a senior services center, that they have activities and meals and all the things that are associated with that. But I think it's going to vary, to be honest, Senator.
Thank you. You have a follow-up question?
Yes, sir. You mentioned it's like a capitated fee, and so there's an incentive from the provider, the PACE provider, to use these wraparound services and try to keep them out of the hospital and that kind of thing. But it also seems, it says transportation's included. I mean, what if they are real profit-oriented and are like, no, we're not going to take you to get your hair cut, or, you already did that. We're only going to do that 6 times a year, or, I mean, who's overlooking all this and making sure that making money doesn't get in the way of taking care of the
Yes, sir.
patient or the...
So a PACE program is going to be very equivalent to a license program, even though we're not seeking licensing. We're going to follow all the certification through the Medicare guidance, so they would be able to complain to the department. It would meet that similar complaint. And then just as a reminder, this is a total voluntary program. If they're truly dissatisfied and can't reach resolution, they can disenroll and go back to regular Medicaid services, whether that be HCBS or they could go to a nursing home. I will say that if they digress and they end up in a nursing home, though, in the PACE program, PACE is responsible for that nursing home care. So there's truly incentive to try and keep them not only out of the hospital but out of the nursing home.
Makes sense. Gotcha.
Yeah, just add one thing to that. So this is all value-based care is what it sounds like, and the incentives are for the quality to drive the cost, right? So the outcome should be, there's motivation for the outcomes to be better.
Absolutely.
Which then costs less money. I mean, that's how value-based programs work.
That's right. I mean, you know, how often do I say in this committee that quality drives price? Yeah, right. Number 2, 3?
That's right, 3. Thank you, Mr. Chair. Thank you for being with us. And I apologize that the chairman had presented his bill pretty much almost completed when I got here. So if I'm being repetitive, I apologize. But we've had community-based services for eons, and it's been characterized as being underfunded. You know, we're always pushing for more funding of community-based services. How does that reality sync up with this proposal?
Yes, ma'am. Well, Senator, I'll answer that, and then if Joe needs to, he can as well. So to me, they live together. So you're right. For many years now, we've been trying to continue to increase funding for home and community-based services, largely through Medicaid waivers, to keep people in the community longer who do have a skilled nursing home level of care, and we're doing that. We continue to do that. This will give us just another route, another choice, if you will, for individuals who have Medicare and Medicaid to do it a different way. So it's not through a Medicaid waiver, but it's through this PACE model, and which is a CAPA, so it's different entirely from a fee-for-service provider through home and community-based services, because it's a capitated program. They're all fee-for-service at this time. And so this will be different, but it just gives another choice for that same population. Same population, different option. So it's just another way of serving people who, as we all know, are the people really Medicare has all the way back to the 60s been most targeted to. Age blind, disabled, frail elderly. Mm-hmm. And so it kind of captures that group with another opportunity is the way I would describe it, and Joe may have a better answer.
Mr. Hood, you got anything to add? Or?
Yes, just one other thing, and that is, remember, this is a capitated rate, and as the chairman referenced, the community-based services are on a waiver, and those rates are Medicaid rates, which are really at the, to raise those rates would be an ask to the legislature to do. I mean, I've been very kind this past year. We've raised rates for the first time for many of those waiver programs in a long time. The difference here is a capitated rate. Much like the CMOs, it gets done by an actuary every year. And these are largely driven by Medicare rates because this is a Medicare program. So they're not really set by Medicaid. So you've got an actuarial rate, which is going to be revisited every year and updated. And then you've also got the Medicare participation, which is driving that, which ensures that you're going to get a competitive rate and that it's going to remain so as you go forward.
It sounds like, why is it taking us so long? So, right. Okay. Any other questions from the committee? Thank you, Mr. Hood, Chief Operating Officer of DCH. And certainly.
So is it anticipated that this approach will have a cost savings that the home and community-based care does not have? It's a cheaper, less costly way to deliver with the hope of better services? I mean, is that
Senator Orrock, I would Mr. Hood may have to answer that. They both offer savings, dramatic cost savings over skilled nursing. Right. Institutional placement. Right. So the degree to which one may be cheaper than the other, it may be that Mr. Hood should answer.
Well, Medicare is subsidizing this program, so I mean, I would say that's a large part of why we expect savings. I don't know, there's certainly not going to be savings per se immediately, because what you're doing is you're going from a standard of care where there is no management. Largely, most of these members are in fee-for-service today, and they are managing their own care. And then what would traditionally happen is they would reach a point where they have to go to the nursing home, their family or themselves, and then they go. If they elected PACE, then that option would divert them from a nursing home. You're going to see savings because of that managed care over time and the diversion from the nursing home. But from a financial standpoint, this next year, I don't expect to see savings. We did a review of that, and what we expect is that it's budget neutral in the first years. But it's really difficult to pin that down because you're trying to estimate who is indeed going to go to a nursing home versus not. And we did our best attempt with that with the actuaries and determined that we believe we'd be budget neutral. And in the long term, of course, we would have savings because we would not be sending people to a nursing home and keeping them out of the hospital, and just the managed care component part.
But yet this bill exempts PACE from meeting the requirements of a managed care organization, right?
Right, because we are using the Medicare standards and all the Medicare certifications, and that's what we want to use to manage the program because of that subsidy and their participation. That's the reason for that. Whereas if you had a CMO, that is not the case. That is purely Medicaid. Or if you had an HMO like Kaiser, that's a private entity. That's generally what's expected for in the statute and what it would regulate. And this is separate and apart because of the Medicare component.
Right, and I think a distinct and important difference is that there's a management of the overall needs of the client, as opposed to relying on the client's own personal support system to manage all of that. Isn't that a
Absolutely.
integral?
Absolutely.
It's a piece of the puzzle, as we like to say here. All righty, I'm not sure there's a wrap-up that's needed on this one, so
Consider us wrapped.
we got Senator Chairman Sessler says move, do pass. We have a seconded. We'll do Chairman Walker, and any further discussion? Can't imagine there would be, so we are, all those in favor say aye. All those opposed, like sign. Passes unanimously. Thank you, Chairman Petrie, and I'll be happy to carry that bill.
Thank you, Chairman. I'll get it to you.
All right, as I said earlier, we're going to swap out here because Leader Williamson is not here. I'm going to carry the bill for him, so I'm going to turn it over to my vice chair.
Okay, our next bill is House Bill 1083, and that's Representative Williamson's bill. And the LC that I have is 540348S, which is committee sub. Is that what you have, Senator Watson?
That is it.
Okay, floor is yours.
Thank you, Chair Lady. This has basically a date change relating to adult residential mental health programs. We passed this legislation a couple years ago, and the rules took longer than we anticipated, but the rules have been done. They just didn't get done until the end of last year. So folks who have been in this adult residential mental health program have had provisional licenses, and this just basically extends the license from, as you'll see, from those dates on lines 30 from December to June, so about a year and a half, and the same for line 33, and then again about a year and a half on line 38. And that's it.
I have one question for you, Mr. Chair. So is it correct that the rules have been promulgated, but they just haven't had the public comment period and all of that? Or they have not been promulgated?
Yeah, I'd love that. Mr. Hood can save me.
So the rules we had draft rules and we had public comment, and we have not reached resolution on all the public comment that was there. And some of those comments were from the primary provider who had the provisional license. So we need additional time to get to a place where we feel comfortable to come back to the board and adopt final rules to try and work through those commentary. We certainly don't want to displace the provisional license that is in place. So the legislation is to extend that while we continue to work through that process.
Okay, questions from the committee? We have one person signed up to speak. Stan Jones?
Joe Hood has reported what I would have said. Stan Jones, I represent Skyland Trail, which is the provider that has been a personal care home before, and we added a residential subacute program for adults like we had one for children. We just need a little bit more time to get finished on the implementation.
Okay, any questions? Okay. Okay, we have a motion to pass by substitute, right? Yeah, LC 5403448S, and need a second. Okay, Senator Butler. And any further discussion? Okay, all in favor say aye. Aye. Opposed? Same sign. Okay, the bill passes by substitute. Thank you.
So just a heads up, on Wednesday we'll be meeting. We have 3 or 4 bills that are already teed up, and we'll continue to march through. We have really, counting this one, we have 4 meetings, maybe 5 meetings to get all the bills done, and that's not just for HHS, that's for everybody. So just FYI, really appreciate that. Meeting adjourned.